discussion today. We'll look at blood physiology, and these notes were prepared by Dr. Frank. Okay. So basically, we've looked at the red blood cell in full detail. We've looked at the coagulation cascade, I'm sure, with Dr. Frank. Today, we want to look at white blood cells. Now, white blood cells are important cells of the immune system, like we are going to look at there. This is in terms of, this diagram is, we looked at erythropoiesis, correct? Now, I constantly need feedback because I don't know what was taught and what was taught. Did we look at erythropoiesis, this formation of red blood cells here? We did?
Yes, sir. We did.
Okay. Thank you very much. So, in terms of red cell origin and production of RBCs, they are coming from the undifferentiated pluripotential stem cell in the bone marrow. So this is occurring in the bone marrow. In most cases than not, what we need you to remember is the differentiation of red blood cells. You can have an idea of how white blood cells are produced, but I think that is more of immunology than physiology. So in immunology, you will have to remember how all these granulocytes and lymphocytes are made. For us, what we want you to remember in physiology is very importantly the red blood cells, and then these other white blood cells. What we need you to remember in terms of cells is, look at this very carefully. You have the monocytes, granulocytes, and platelets are coming from the myeloid stem cell, okay? The myeloid stem cell. And then cells of the adaptive immunity, the lymphoid stem cell, is where you get your lymphocytes. So lymphocyte and lymphoid tissues come from that. Otherwise, in terms of the breakdown of how you need to know them, we don't really expect you to know in terms of the white blood cells. Okay. So having discussed that, we now move on to the individual cells themselves. We have about 5 types. Okay, now I have to constantly be admitting people. So in terms of white blood cells, you have 5 types, okay? You have agranulocytes. So agranulocytes, agra means that there is no nodules that are present in the cell. And then you have granulocytes. Granulocytes just simply means you have granules or nodules that are present in the cell. If you look at these 2 types of cells and you separate them, you can literally see that in here you have those round things there. I don't know if you can see my pointer. You have round things that are present in there. You have those round kind of like nodules present in the cell. And then again here you have nodules that are present in the cell. So these are granulocytes, meaning that in their cytoplasm you have granules that are present. And these granules are going to contain different molecules that are important in attacking microorganisms, or rather antigens, or any foreign body that has been brought into the body, has been ingested into the body. And we'll look at the types of granules that are present in each of the granulocytes. I used to remember this as BEN, B-E-N. So basophils, eosinophils, and neutrophils have granules that are present in their cytoplasm. I think it was here where I was teaching bone and blood in anatomy, and I tried to differentiate how these 3 cells are differentiated. And when you look at them, they are differentiated based on their nuclei that is present here. If you look at the eosinophils or eosinophils, they are bilobed. It has a bilobe nucleus. So granulocytes, all of them have granules. Eosinophils are bilobed. So you can see that bilobe nucleus. In here, you have those multiple nuclei in your neutrophils. And in your basophils, sometimes you have a single lobe and or a large nucleus that is present. So just look up that, just briefly on anatomy. Then in here, you have the lymphocytes, okay? The lymphocytes and the monocytes, which are basically the same types of cells at different stages of development. So what are white blood cells? White blood cells are sometimes referred to as leukocytes, like I mentioned in the previous lecture. Now, allow me to present to you this at the end. What I want you to now know. Okay, so let's skip our discussion. We'll come back to that. What I want us to know is agglutination of red blood cells. Okay, agglutination of red blood cells, or the ABO classification of blood cells. Okay. We did blood grouping with Dr. Frank, isn't it?
Yes.
Okay, so if we did blood grouping and we looked at how these are able to agglutinate, I need feedback, people. I wasn't in your class. Anyone to
Yes,
come
sir.
through for us?
We looked at it.
I didn't hear that. Please just repeat for me. I didn't hear what you said.
I'm saying yes, we did.
And
We
okay, thank you. Did we do the agglutination part and how you're able to transfer blood from one person to another?
Yes, we did, sir. Doc.
Oh, so do I have to go through agglutination? Because I think it's more important than the white blood cells. No, it's okay. We're good here.
I don't.
you can go through
We
it.
didn't do that.
We didn't do that. Okay. So I'll come back to the white blood cells, but I think what's important in our discussion and what I need you to remember is this agglutination. So what is agglutination? When you are doing the ABO system, you realize that on the surface of red blood cells, you have molecules we call antigens, okay? Can someone help us with the definition of an antigen? What is an antigen? Under 1 minute, quickly, guys, we need to go through the past paper.
A foreign substance in the body.
Okay, so this is a foreign substance in the body or any microorganism that is recognized by cells of the immune system. So we're saying that on the surface of red blood cells, you have molecules we're calling antigens. And on the ABO system, those antigens can be the A antigen in blood group A. You can have the B antigens in blood group B. And then you can have both the A and B antigens in blood group AB. And then you have blood group O that doesn't have any of these antigens. Now, when you are transferring blood from one person to another, there is a reaction that takes place. This reaction is called an agglutination. What is an agglutination? This is where the immune cells of one individual identify antigens on the red blood cells and attack these red blood cells, producing what is called hemolysis. So when you put two blood groups that are not similar or that are not compatible, an agglutination reaction will take place, leading down to the breakdown of those red blood cells. And that's what we mean when we say that blood is incompatible. So with the ABO blood system, it's going to help us classify or identify which blood we're able to give to an individual or which blood we're not able to give to an individual based on the antigens that are present on the cell. I want you to remember that for an agglutination reaction to take place, you need an antigen and an antibody. It's that interaction of an antigen and an antibody that will result in hemolysis or an agglutination reaction. Okay, so I hope I've made that clear, unless we have any questions. This is what I was just explaining about the blood groups and how all those reactions are taking place. So now, if you look at here, you have this antigen on the surface of the red blood cell. And then in the plasma, you have this antibody that is present. I think this morning for the second years who are in group 3, I was saying that when we're giving blood, we usually give blood as whole blood. We remove this plasma that is present. Yes. Someone had unmuted their mic. Were they about talking, or I proceed? Or there was a question?
I wanted to ask if the class is recorded.
Unless otherwise, I think it's being recorded, but I can check that. Yeah, it's being recorded.
Thank you.
Okay. So I was saying to say, I mentioned for those who are in second year group 3 who attended today's class, I was saying that when we are giving an individual blood, we usually give red cell, whole blood. We don't usually give the plasma. But what I want you to remember is you have these surface antigens on the red blood cells. And then in plasma, remember we split blood into 2 components. There was those red cells, and then there were the plasma, the fluid component of blood. So in the fluid component of blood, you're going to have your anti-A, you have your anti-B. This one does not have any antibodies present, and this one has both anti-A and anti-B antigens. For hemolysis or agglutination to take place, there has to be an interaction between cells of the immune system, which are antibodies, and an antigen, which is going to be recognized as a foreign body.
Excuse me, sir, you're breaking.
I'm breaking. Okay, let me try and reconnect.
Yes, sir.
Sorry about that. Thank you for the feedback. I'm just trying to reconnect my network. Okay, I've changed networks now. Am I still breaking?
So it's me, I could hear you clearly all the way.
Okay, I've moved from Zamtel to Airtel. Can someone else be a tiebreaker? Am I breaking as well on their side?
No, sir, just a thing.
So maybe it's our colleague. So my colleague there, maybe it's your network that is not okay. So try and look at your network. Okay, so for a reaction to take place, for hemolysis or agglutination to take place, we are saying that these antibodies that are present in plasma have to interact with these antigen, and when that happens, they'll cause breakdown of red blood cells. I also mentioned to say you need to remember that when we're giving blood, we usually don't give the plasma component of blood. Okay, we give the whole blood. So let's just have a short discussion under 5 minutes. We want to give blood, this person, type B person, someone with blood group B. What blood can we give them? Can we give them A, B, or O? Someone with blood group B. Quickly, someone to come through. Let's make this more interactive.
We can give them blood group O.
We can give blood group O. Why?
Because O is the universal donor and it doesn't contain any antigens. So I guess it's a perfect match. Even the same type B again, they can receive.
Okay, so that is good, but I don't want you to remember that O is a perfect donor. I want you to be able to explain things physiologically based on the presence of the antigen and the antibodies that are present in the plasma. Okay, so maybe the second person, can someone explain to us Our colleague is correct. We can give someone with type B blood group B itself and blood group O. But what is the physiological basis of that?
I think you can give him blood group B and O. Why O? Because O has no antigens, but it has antibodies which can react with the antigens in A, but the antibodies in blood group O, they are less, so meaning they will react less with the antigens in blood group B.
Okay, so that's the reasoning behind it, isn't it? And remember, I was trying to emphasize the point that when we're giving blood, we don't give plasma. Okay, we don't give these antibodies. Remember, antibodies are found in plasma. So when we're giving blood, we give whole blood, red blood cells. We won't give this plasma. So when we give someone with blood group O here, this person will have very little amount of antibodies A and B, and therefore they will not form a reaction with this B antigen. The antibody that is present in this person's blood will not also attack this guy because he doesn't have any antigens that are present on that cell. So I want you to remember it in that way. Maybe let's just the last example. Blood group AB. What blood? Okay, maybe, yeah, blood group AB. What blood can we give them and why? Is that someone coming through for us?
I think yes. Type AB, they can receive either from A or from B or from O, because
why?
if you talk of blood group O, those ones they don't have antigens. Yeah, so meaning they can blood group O can easily be transferred to type A, B, and if you see A and B, then that one is simply a combination of A, B, meaning it has got antigens that are found in A and in B. So this one they can receive either from A, B, or O.
Okay, very correct. Okay, and also because the other plus what you have said is that these guys don't have any antibodies. They don't have any antibodies. Therefore, if you give them this blood, they will not have anything to be attacked. So remember, if we're giving blood, we're giving whole blood. We're not giving the plasma component of blood. So I hope you've understood this agglutination, very, very important, and why it's happening and how it takes place. Okay. Any questions under blood
got a question.
transfusion? Yes.
I've got a question.
Yes,
Yes.
please.
Is there an instance where you say is there we've got type A? So is there where we've got maybe type A positive, type A negative, type B positive, type B negative? Is there such a situation?
Yes, there is. And that situation comes about because we are integrating two blood systems, the ABO system and the RH system. We're about to go to the RH system just now. Okay. So, for example, if someone is blood group A, we're going to say they are blood group A. And then if they are RH positive, we're going to say they are A plus, meaning that they are blood group A in the ABO system. And then in the RH system, they are positive for the rhesus factor. We'll look at that just now. Does that answer your question? Okay, I don't know if it does. So any questions on blood group agglutination? I hope we've understood how that is happening and not saying that there is a universal donor, there is a universal recipient. You should know why this guy is called a universal recipient, why this guy is called a universal donor, universal recipient. Physiologically, why? Okay, if we don't have any questions, we move on to RH incompatibility. Okay, again, my assumption is that you did this in your class, the RH grouping, correct? Hello?
Yes.
Okay. And we looked at how that there is that D antigen that is present on the red blood cells, isn't it? Can I have a tiebreaker, please?
Yes.
We did it? Okay, so if we did, what you just have to remember is this component here. An RH negative person cannot receive blood from an RH positive person, whereas the RH person can receive blood from an RH person. Why do you think this is the case? Anyone to come through for us? Why do you think
Yes,
this
yes,
statement
sir.
is like this? Was that someone who was trying to help us?
What I can say is that the RH system is determined by the antigen D. So it is the presence, so it is the presence of that D that determines whether someone is rhesus positive or rhesus negative. So when someone has got a blood type, let's say A negative, it means that they lack that antigen D. So if they lack that anti-D, it means that there will be no factor that can cause agglutination with the other type of blood system. Let's say cis type A negative, can give blood to someone who is A positive, but A positive cannot give blood to someone who is A negative. I don't know. Maybe I've just mixed up some things, but I hope you got the point.
Yeah, I think I got your point. So if you remember from your blood group system, remember that in RH negative people, they are capable of producing antibodies, okay, against the D antigen which is present in the RH person. And therefore, if you give blood to this person, the antibodies that are present to attack this guy and they'll cause agglutination. The only difference between the ABO system and the RH system is that in the ABO system, the reaction takes place immediately. Why does it take place immediately? Because the serum, the plasma, contains antibodies that are already present in the plasma. In the RH system, when someone is exposed for the first time, there will be minimal reaction taking place. But then what happens is someone gets or has to have antibodies that are produced. And then when they get a second exposure, the immune system amplifies the reaction, such as the reaction or the hemolysis takes place immediately. Okay. So remember that statement and try also to understand why RH people can receive blood from RH positive cannot, whilst RH people can receive blood from RH negative people. Okay. An important clinical application is what you call erythroblastosis fetalis. In some books, it's referred to as hydrops fetalis. Okay, hydrops fetalis. What is happening in hydrops fetalis? Remember, we are saying that you have an RH woman. She has an RH positive fetus. These two systems will not mix because blood from the child and the mother does not mix because of the placenta barrier. However, what happens is that during delivery, there's some blood mixing. There's some blood mixing from the fetus to the mother. So what you're essentially doing is that you're introducing RH blood into a mother's RH negative blood. And remember, we said someone who is RH negative cannot receive blood from someone who is RH positive. So in the first pregnancy, when they get when the mother gets this blood, remember we said that in the first exposure, there will be formation of antibodies. Okay, so there'll be very few antibodies that will be produced, and the immune system won't be as strong as it is supposed to be. However, when someone conceives the second time, okay, and then let's say they have a baby who is Rh negative, okay, or Rh, yes, Rh negative. So in the first instance, the mother was Rh negative. They became sensitized, or antibodies got produced because of production of RBCs. In the second pregnancy, this mother now has a child who is Rh negative. Now, I don't know, I don't have a pen here. Follow the scenario. If you have a pen somewhere, write it somewhere. Pregnancy 1, there is exposure. Mother is exposed to Rh positive. So Rh negative develops antibodies against the anti-D body. In pregnancy 2, mother is still Rh negative, but has antibodies against Rh positive child. So in pregnancy 2, let's say the mother now has a fetus that is Rh positive. Okay, now this mother is Rh negative, but has developed antibodies against the D antigen in Rh positive because of the previous exposure. So in the second fetus, these antibodies that are present in here will penetrate the placental barrier. Remember, blood does not penetrate through the placental barrier, but antigens are able to penetrate through the placental barrier. So this mother was Rh negative, has now developed antibodies which are anti-D and are able to attack Rh blood. And therefore, when the person now has the second pregnancy, the antibodies will penetrate through the placenta and will start causing hemolysis in the child. Okay, and that hemolysis is what is going to cause hemolytic anemia, and that is what we call erythroblastosis fetalis. So you will see a woman who is going to be having pregnancy losses every now and then in the society they will say "Vanamulowa," isn't it? So that's the physiological basis in that. And so such women, we usually give them anti-D prophylaxis to prevent this incompatibility. Have I lost people with my explanation on that? I don't know if I was clear enough. I don't have a pen and a pointer, but if you followed me, I was trying to explain that. Have I lost anyone?
Sir, I've
No,
got a
sir.
question.
Yes.
Yes, sir. The same, he said, so after each pregnancy, the mother will receive RHD. So now, this one, I saw somewhere where they were saying like, if at all the mother starts maybe receiving miscarriages each and after every pregnancy, then they said they can prevent this one by giving them, is it Rogam? Is it the same as the anti-RHD, the Rogam?
Okay, so Rogam, probably it's a drug name. Okay, so when you get a drug such as, let's say, Panadol is just a drug name. It's a company name. What is present there is the paracetamol, which you are going to learn about. So that Rogam, I'm thinking it's the drug, it's the brand name. But if you look at the constituents that are present, you obviously find that there's the anti-D antigen that is there. Okay. So in other books or in other literature, you're going to find that as hydrops fetalis, okay? Hydrops fetalis as a result of this crossing of the thing. So you should be able to explain the physiological basis of erythroblastosis fetalis or hydrops fetalis. Is that okay?
Sir.
Yes?
Does the RH negative of the mother does it change to positive after the second pregnancy?
Remember, it doesn't change to negative. The only thing that happens is that you've now produced what? Antibodies. So you now have antibodies in the plasma, and antibodies are able to cross the placenta. So they cross the placenta and they go and attack the fetal blood. So to answer your question, no, the mother will continue being Rh negative, but their blood is going to have what? These antibodies. And these antibodies are what is going to cause the agglutination. Yes.
Is it the antibodies that are produced due to exposure? Are they the
Yes.
IgM?
Yes, IgM,
Oh.
IgG. But in the
Okay.
secondary response, usually it's the IgG antibodies.
Sir, so now for the fetus to have Rh positive, then for the mother, meaning they have Rh negative. So does it mean that the fetus inherits the Rh positive from the father, or what?
Remember, these are genetics. I'm sure with Dr. Frank, you looked at Mendelian genetics. So these are genetics. So for you to inherit them, remember it's coming from both the father and the mother. So you have that incompatibility, the dominance and the recessive genes, you remember them? So it's inheritance. They are both coming from the mother and the father. So depending on whether it's dominant or it's recessive, it gives you the Rh positive. If it's recessive, it will give you an Rh negative. Remember that one?
Yes, sir. Remember.
Okay.
Thank you.
If there are not any questions and if we have understood
Excuse
that,
me, sir.
yes.
When you're talking about the antibodies, going through the placenta, is it just the IgG which can pass through the placenta to the fetus, or is the IgM also
So I
able to?
said you have both the IgG and the IgM, but you have two reactions that are taking place. You have the first reaction, which is weak, which is your primary response, and usually that is your IgM. And then in your secondary response, you have your IgG. So both are able to penetrate, to answer your question.
Okay, thank you.
So,
okay, yes.
Okay, so what if, let's say, the baby is Rh negative and the mother is Rh positive? So does it also happen in this case where the baby will be affected, or what?
Can someone try to answer that question for me? Did we get his question? Is there anyone from the group that is able to answer that question?
Let me give it a try, sir.
Okay, go ahead.
I think the same situation will work because if you see the baby will be Rh negative, then the mother is Rh positive, meaning antibodies will be formed, meaning the baby will be considered as a foreign product, meaning the antibodies will act to that fetus. So the same situation will occur the erythroblastosis fetalis.
Okay. Do other people agree with that?
So nothing happens.
Okay, why do you think nothing is going to happen? The person has gone.
I think nothing happens because the baby will get sensitized because there's that mixing of blood. So they'll develop the antibodies, but then they'll grow up and everything, but they won't have a second encounter because you don't get pregnant twice, if that makes sense.
So The baby is Rh positive. Okay? Is that the scenario our colleague gave us? The baby is Rh positive. Look at this statement. I thought people would read here. The baby is Rh positive, meaning that they can receive blood from an Rh negative person. Sorry, we're saying that the baby is Rh negative, huh?
Yes, sir.
Did I get the
The
scenario?
baby negative.
The baby is negative. No, if the baby is negative and the mother is what?
Positive.
If the mother is no, then there will be nothing is going to happen, because remember, a mother who is Rh positive does not produce any what? Antibodies. There are no antibodies in someone who is Rh positive. So there's nothing crossing the placenta. Does that answer your question? Have you understood it?
Yes, sir. Thank you very much.
Okay. I think I didn't get your
Repeat,
question.
sir. I'm lost here.
If the mother is Rh positive and the baby is Rh negative, someone who is Rh positive from your discussion does not have anti-D antibodies, isn't it? These antibodies are not present. So there will be nothing to cross the placenta because the mother doesn't have any antibodies. Antibodies are only produced when the mother is Rh negative and they've been exposed to Rh positive blood. So if the mother is Rh positive, it means that there are no antibodies being produced and therefore there's nothing that is crossing the placenta. It can only happen if the mother is Rh negative, because then antibodies can be produced. I don't know if I've tried to answer the questions for our colleagues. Have we tried?
Yes, sir.
Okay.
So
try to
first, before you can move on, does the mixture during the mother to child during delivery, does it happen during the cutting of the umbilical cord, or is just like the blood itself just get mixed up?
So it doesn't usually get mixed up. Usually it's cutting. It's usually so usually this happens when you have trauma as the baby is coming out, and then of course when cutting of the umbilical cord. But no, when cutting of the umbilical cord, no. Usually it's trauma. So as the baby is coming out, there's trauma that occurs there. There are what you call perineal tears. You come and see them later, okay? But because of the trauma to the birth canal, that is usually what causes the mixing of blood, and not necessarily the umbilical cord cutting. Okay.
Thank you very much, sir.
So if there are no questions, we'll look at the types of blood transfusions. We have the direct, indirect, and auto hemotransfusion. So the direct, remember, it's like the ABO system. So you put blood, it directly clots. Indirect is like what is happening in the fetus. Remember the Rh incompatibility. Auto hemotransfusion, this is where you get blood. So indirectly, you are using that, what did I say? Yeah, it's like the Rh incompatibility. It's as a result of that antibodies that are going directly and going to cause hemolysis in a person. In auto hemotransfusion, this is you're transferring blood to the same person. So probably if we anticipate that you're going to have a theater in the future or in whatever time, we get blood from you and then we store it for you, and later we come and give you your blood for the transfusion. Indirect sometimes happen in children where you are able to give blood in vitro. So if you've heard of, I think in other countries they are doing it, whether you give a fetus blood. In fact, this fetus hydrops fetalis is now being treated. Fetuses are able to be given blood in utero. Okay. those are some of the things that you look out for when you're checking for blood groups. Our colleague asked a very important question. We usually mix the ABO system and the rhesus system. So this, we're going to call it A plus, O plus, B plus, B minus. So we're saying that they have the antigen A and they're either rhesus positive or rhesus negative. When you're asked to check blood by the doctors or any other person, what you're going to look out for are those two things. And then you're also going to look at the name of the donor and the name of the recipient. And then you're going to write them down there like that. Okay. Quickly, so if we don't have any questions on that, I'll quickly look at white cells. I thought it was important to discuss that first, and then look at the white cells, which we discussed in detail when we were doing anatomy. So I won't take too much time on that so that we answer questions. Okay. I promise to be done within an hour so that I can answer your questions. What's the time now? 52. Okay, so I'll have to do cells in like 15 minutes. But if I'm too fast, you stop me. But I want us to answer more questions than discussions today. Yes.
Okay. Is it that always, whenever we are doing a blood transfusion, we consider the antigen of the donor and the antibodies of the recipient?
No. We don't do that. We don't do that. We always consider the ABO system, which looks at the antigen. So we're going to look at the antigen of both the donor and the recipient. Remember how I was mentioning that when we are giving blood, usually we remove the what? The plasma. So you don't have antibodies usually that are present. So we give antigens of, when we are checking blood, we check the antigens of both the donor and the recipient. Okay, we quickly course through white blood cells. I don't know if people were present in the anatomy lecture that I gave on blood. I want to spend more time answering questions today. So I'll rush through the white blood cells quickly. If I'm too fast, please stop me so that we attend to the concerns. We don't want to just rush through without people understanding. So I had started talking about the granulocytes and their granulocytes. And I think I mentioned that the difference is basically in the presence of the granules that are present in the cells. And here you don't have any granules. Okay. White blood cells, sometimes referred to as leukocytes, are basically cells of the immune system. So these are cells of the immune system, and these cells are important in defending the body against organisms or antigens that come into the blood. So what are their functions? They seek. So what do we mean by seek? We are saying that they identify. Okay, so they identify the antigen or the foreign body or the microorganism. After identifying it, they are going to destroy it or break it down. So they are going to destroy invading microorganisms. In some instances, they destroy cancer cells, although this is very, very rare. Usually when you develop cancer, it just overwhelms the cell body. Another important thing about phagocytes is that they carry dead debris or cells that have been injured. So they carry them and probably go and deposit them in the lymphoid organs, which we looked at, was it the other week? Okay. So where do these granulocytes get their name? They get their name from phagocytosis. So to phagocytose is like cell swallowing. So you ingest something. Okay, so this is a cell. Do I have any diagram in here? Okay, unfortunately I don't. So if this is a microorganism here, the cell is going to ingest that microorganism. It's going to engulf it. It's going to encircle it. And once it encircles it, remember, these are granulocytes. So they have different granules that are present in there. And when those granules are released or activated, they contain peroxidases or oxidative enzymes that are able to break down the phagosized material. Okay. So phagocytes, now I wasn't preparing this slide, so I will have to be trying to read and also explain at the same time. So phagocytes is selective for the material that is phagosized. So what do we mean here? Most of the phagocytes are only able to identify specific type of bacteria or microorganisms. Also, the granules that are present in the cells only destroy certain microorganisms and bacteria. In fact, I think there is a condition where, I've forgotten the name, where you don't have a specific granule that can digest or break down a certain microorganism. So when this phagocyte engulfs or ingests the microorganism, it just accumulates in that phagocyte or in that microorganism. Of course, how does it select? It's dependent on mainly the proteins that are present on the surface, the protein bodies, and those protein bodies are usually what you call antibodies. Okay. So the selection of which microorganism to be digested is referred to as what? Opsonization. Opsonization. Please stop me if you have a question or a query. Okay. So
okay, sir.
Yes.
I came across a question which stated that which two leukocytes undergo phagocytosis?
Okay, maybe, okay, let me just look at these slides. So when we start looking at those which two cells, then we should be able to answer that question. Okay, from a second guess, which two cells do you think will undergo phagocytosis?
I think the monocytes and the neutrophils.
Why the monocytes? We'll explain at the end of the lecture. Is that correct?
Yes, sir.
So at the end of the lecture, we should be able to understand which cells are going to go through that. I would say the neutrophils and the eosinophils, but we're going to explain which ones based on our discussion today. Is that okay?
Yes, sir.
Okay. So remember, diapedesis, I think we explained this when I was looking at blood cells in anatomy. Okay. I don't know how many people attended that lecture. So when white blood cells are entering tissues, that is called diapedesis, because maybe this is cell 1 here, this is cell 2 here. In between these cells, so they become loose, and these white blood cells are able to pass through the cells like that. So neutrophils and monophils can squeeze through the pores of blood and capillaries by diapedesis. So like I was saying, you have one cell here, one cell here. In between those gap junctions that are present, cells are able to pass through, okay? In terms of motion, of course, you have that ameboid movement. Chemotaxis just means that these white blood cells are going to be attracted to the place where there is an antigen or a microorganism. So when you have a microorganism or an antigen or a site of inflammation, inflammation is just basically where there is tissue injury as a result of a microorganism that is present, and therefore the immune system is getting mounted there. So white blood cells will be attracted to antigens, microorganism, or collectively what is called an inflamed tissue. An inflamed tissue is just any tissue or place where you have tissue damage as a result of, it can either be mechanical or production of antibodies to that area. Okay. So what are we saying? We are saying that, let's say here there's a microorganism, okay? So if there's a microorganism here, most of these cells, okay, so these are cells of the immune system, they're in blood, they will start penetrating out or coming out, getting attracted to the place where you have your inflammation or where the antigen is present. Okay, so chemostasis is just like what is attracting these white blood cells or cells of the immune system to the site of inflammation or to the site where the antigen or the foreign microorganism is present. Okay. And I was explaining the other time to say this is usually occurring in between a capillary. So you can see this is one cell here, okay? And then you probably... Are we able to see the screen now?
Yes, sir. Yes, sir.
Okay. So I was saying
Doc.
these values here that are present, which percentage forms monocytes? So when we say someone has lymphocytosis, meaning that they have an increased or an elevated number of what? Of lymphocytes in their red blood cells. Okay. What is the characteristics of white blood cell? I mentioned this when we were looking at plasma proteins, and I think I was saying, oh, no, I wasn't teaching the entire class, sorry. The class I was teaching, I mentioned to say the reason you have plasma proteins constituting less than 1% in terms of white blood cells is because of the rapid breakdown of these white blood cells. They don't have a long lifespan. Their lifespan is just basically about 4 to 8 hours. And in 4 to 5 days. Some books will say 4 to 7 days, okay? So they have a very, very short lifespan. And sometimes these are moving in blood in an inactive form. They only get activated once there is the presence of an antigen. Okay. For monocytes, of course, there's that short period of time, about 10 to 20 hours, before wandering through the capillaries and becoming. But what is important here is this, okay? The 4 to 5 days that is present there. So in terms of their lifespan, and this is because of their rapid breakdown. So once they are produced, they easily get broken down. Okay. So after diapedesis, we defined it as the movement of the white cells or the cells of the immune system from the capillaries into the tissues. And that is what causes them to become larger, or they become more increased in size for them to be able to perform their function. Polymorphonuclear granulocytes, look at the word here. Poly means multiple. So they have multiple. Morpho means different types of nuclei. And that is how we differentiate neutrophils, eosinophils, and basophils. I used to remember it as Ben. So these have granules that are present in their cytoplasm. But how do we differentiate them is based on the structure of their nucleus, morpho, and how many nucleus they have. That's poly. So they have usually multiple. So if you look at neutrophils will have that multiple, usually 2 or 3 nuclei that is present. You can see that in their cells. What you're seeing in the background, these are red blood cells. So if I take you back to this slide, neutrophils, we said you're supposed to have how many? Look at the percentage, about 62%. So when you get a blood slide, this is a blood slide here, and you look through it, you're able to count the number or the percentage of these basophils, and then you're able to tell whether there's a neutrophilic differential or there's an increase in the number of neutrophils. Our colleague was asking us which leukocytes are capable of phagocytosis. A very good example is the phagocytes. Okay, phagocytes, they have a phagocytic property, meaning that they can engulf or swallow bacteria. Okay. Eosinophils, again, they perform the same function, but these are usually bilobed. You can see there are 2 nuclei that is present there. And again, at the background, you can see the red blood cells that are present. Eosinophils are important. So these ones are important in bacteria. Underline that word. Okay. Neutrophils. So when you have a neutrophilic response, that's what you call it. There's an increase in neutrophils, then you know that most likely you're dealing with a bacterial infection. That is the significance. When you're dealing with a parasitic infection such as worms, you're going to see a eosinophilic response, meaning that there is an elevated number of eosinophils present in your red blood cells. Of course, the basophils, usually these have three usually, okay? So you have those three basophils that are present. These are important in the releasing of histamine and heparin. Allergic reactions such as asthma, okay? So in asthma patients, you're going to see a lot of basophils because these are important in the release of histamine and heparin. So kind of know the function: neutrophils, bacteria, these parasitic infections, okay? And then here you have more of allergic. So those allergic reactions, someone says, I don't eat pork, I don't eat beef because I have these rashes that form all over my body. It means that that pork that they have eaten is being identified as what? As an antigen or as a foreign material, and histamine and heparin are released, causing a rapid flare. Now, I promise that we're going to look at past papers. So 21:30, we start looking at 2 or 3 questions before we close. The other type are the mono, meaning they contain one nucleus and they don't have any granules that are present in their cytoplasm. Okay, so you can see the monocytes. So monocytes and phagocytes, is it monocytes and macrophages, are the same cells, only at different stages. So monocytes are the immature form of macrophages. Okay, so our colleague was actually right when he said lymphocytes. I argued that it's not, I think I said neutrophils and basophils. I meant macrophages. Okay, the macrophages are the ones that are important for phagocytic capacity. So monocytes and macrophages are the same type of cells, only that monocytes are the immature form, and then when they exit the blood and they become mature, we now refer to them as macrophages. So my colleague, I've forgotten your name. You are spot on, huh? The macrophages and the neutrophils are responsible for phagocytic potential. The eosinophils are also important for phagocytosis. Remember, we said that the neutrophils phagocyte bacteria, the eosinophils attack the parasitic worms, but they also undergo phagocytosis. The other cell that undergoes phagocytosis are your macrophages. So macrophages, monocytes. Sometimes in your essays and your tests, we refer to macrophages and we're actually talking about monocytes. So understand that before macrophages become capable of engulfing bacteria in the blood, they circulate as monocytes. Yes, someone wanted to say something?
So, sir, the monocytes are the one that have they are the ones that exist as the largest type of leukocytes because of its type of the nucleus that it has.
I wouldn't say that. I would say why I wouldn't say that is because when they're in blood, these guys are in the inactive phase. They only mature when they exit the blood to become what? Macrophages. So I don't think that is correct. Although I have to confirm, but I don't think so. Is that okay?
Yes, sir.
Okay, and then you have the other types of cells that produce antibodies. We are just looking at agglutination, remember? And we're saying antibodies are important for that hemolysis or the agglutination reaction that was taking place. So what produces antibodies are what? Your lymphocytes. Okay, so your lymphocytes are important in production of antibodies. When you have a lymphocytosis, meaning that there is an elevated number of lymphocytes present, it means that most likely what you're dealing with is a viral infection. Okay, so lymphocytes are important for attacking of viruses. Okay. Again, they do attack cancer cells, but not very strongly. Usually cancer cells are notorious, and they will be able to cause that. So remember, the macrophages or the granulocytes will produce bacteria. Okay, just a moment, guys. Okay, so macrophages will produce the granules that are contained will contain oxidizing agents. I think I've already talked about this earlier on when I talked about hydrogen peroxides, hydroxide ions, or an acidic environment that is going to destroy bacteria. Okay. The other thing sometimes, of course, this is more of anatomy than physiology. Macrophages will have different names in different places. So when you look at macrophages in the liver sinusoids or in the liver, they are referred to as Kupffer cells. In the central nervous system, they are referred to as microglia. In the skin, they are referred to as what? Histocytes. Okay, they are histocytes. So what we're basically saying is that macrophages or monocytes in their immature form, in different places, they will carry different name. In the skin, we're going to call them histocytes. In the liver, we're going to call them Kupffer cells. And then in the brain or the central nervous system, we're going to call them microglial cells. Okay. I think we've already discussed this. We won't waste much time on that. Our colleague who said they would prepare papers for us, can we please have them now?
Should I send all at once or I send them one at a time?
Oh, you're sending them to me. Okay, send them through. Send them through then. Send the ones that you think we should start with, or send all of them anyway, and then we can look at it. Maybe we can answer some questions in the next few minutes. Yes, please.
Does also immunity part of, like, do they ask questions concerning immunity?
Okay, so of course you have the innate immunity and the acquired immunity. We will ask you if maybe one or two, but really this is your immunology. And if you look at it, I've tried to approach this lecture a bit strategically because maybe the only thing you have to know is which cells are important in the, which cells are found in the innate. Sorry, let me just drink some water. So under innate cells, just try and look at which cells do we find in the cellular innate system, in the humoral innate system, and then in the acquired as well, cellular and humoral. So here you have your B lymphocytes or the lymphocytes. In fact, here both of them are lymphocytes, and then so just try and look at the types of cells that we find in your innate immune system and what you look at in your acquired immune system or your secondary immune system. But really, this is more of immunology than physiology. Any questions before we try and answer the questions that are ahead of us?
So which antibody is responsible for fighting parasitic infections?
Didn't we say that's the job of the eosinophils? Parasitic infection, we said that is a function of your eosinophils.
I was asking of an antibody, an immunoglobulin.
No, antibodies are not. So antibodies usually are not related to parasitic infections. Antibodies are more related to viral and bacterial infections. Okay. And if you remember from my discussion, I was saying that when you look at a differential count, so you'll be ordering full blood counts when you become doctors. So when you order that and you see that there is an elevation of eosinophils, then you realize that what I'm dealing with most likely a parasitic infection. When you see more of lymphocytosis or antibodies, then you realize that most likely I'm dealing with, number one, a viral infection or a bacterial infection. Okay? So they are kind of specific in what they attack.
So,
yes,
kindly just explain a little bit about lymphoma.
Okay, lymphoma. So lymphoma is a cancer of lymphocytes. Okay, so remember how in cancer, we're saying that a cancer is just abnormal proliferation of cells. So when you have a lymphoma, you have an abnormal proliferation of lymphocytes. Where are these lymphocytes produced? Remember, they are produced in the bone marrow. So a lymphoma can attack the bone marrow. It can attack the lymphatic system. I think, was it the other day when we were looking at the lymphatic system? So you're going to have these large amount of cells or masses being produced, and the primary cells that you're going to have are a lymphoma or lymphocytes. So a lymphoma is just a tumor of the lymphocytes. And there are different types of lymphoma, whether it's a B cell lymphoma or a T cell lymphoma. But again, that's beyond the scope of our lecture. Is that okay?
So, sir, there's no difference between leukemia and lymphoma.
Now, leukemia is, what do you think leukemia is?
A cancer of the white blood cells.
So you see, you have a difference because in lymphoma, it's the lymphocytes. In leukemia, it's the leukocytes. And usually this is based on the bone marrow. Where is that diagram? That one there. So when you have a lymphoma, mainly if it's in the bone marrow, it's from the lymphoid stem cells. So all these cells will be affected. If you have a leukemia, you are most likely talking about the myeloid stem cells or the leukocytes, granulocytes there. Okay?
Yes, sir.
Yes?
So, sir, is leukopenia and leukemia same or what? It's kind of confuses me.
Totally different. Leukopenia. Penia means absence or very low. So if someone has leukopenia, it means that they have very low number of leukocytes. It goes back to what I was telling you about how you need to remember this slide here, that slide. So if someone comes in and they say they have leukopenia, what we're saying is that they have a reduced number of neutrophils, eosinophils, and basophils. They are very, very low. So we say that that is leukopenia. If we say someone has a pancytopenia, it means that basically all the cell types are reduced. Don't worry, you'll learn those terms when you come to your fourth year in pathology. Any other question before we tackle the paper? So we can go to our paper.
Sir.
Yes?
Yes, we can go.
Oh, okay. Are we good, everybody? We can start looking at, are we comfortable with this paper or other people suggest otherwise? We can start from anywhere.
Yes.
I've liked this question here. Why can't I zoom in? People are able to see my slide, correct?
Yes, sir.
Just a moment. Wow. I'm very computer illiterate, so pardon me. Where are the slides that have been sent? Where are the photos that have been sent? Oh, those are the photos. So I'm interested in question 75. Let's try and answer it together. Rhesus factor. This is true or false? Okay. I think maybe people can answer and then we try, then I come in, isn't it? So someone to answer A, another person to answer B, another person to answer C, another person to answer D. Quickly, so that we tackle more questions. Volunteers, guys, volunteers. There's no wrong answer. We are all discussing here.
Okay, for A,
Yeah.
I go with false.
So what you do is you read the option A and then you tell us why you think it's false.
Okay, the negative people normally contain small amount of anti-D in the plasma. My answer I go for is false. The reason is that the antigen D is only present in Rh positive people.
Okay. Is there anyone who argues or we all agree with him? Guys, this is an interactive session. The more you answer, the more questions we tackle. Let's make it interactive.
And in addition to that, sir.
Yeah.
Yeah, because the reason why we are saying that RH are positive, what is making it to be positive? Because of the antigen that is present, which is D. So in RH negative, they are having, they don't have the antigen D. This is why we are referring to be negative people, because they don't have the RH factor, which is antigen D.
Okay. I agree with you, but is there any person in the class who disagrees? I think his explanation is quite straightforward. Is there any person who thinks otherwise?
No.
Okay. So another person can answer B. So I think it's false as well. So Rh negative people do not contain anti-D in their plasma. They contain antibodies. Okay. Okay. Yeah, you're right. Okay, so B, someone read B and tell us what they think.
B is saying antigen is confined to the red blood cell. I think that's not true because we can have antigens in the body fluids and also in the epithelium.
So, okay, someone says it's true. Another person, what do they think?
True.
I said that it's not true.
You say it is not true? Is this the same
Yes.
person who... Okay, so when you're answering, mention your name so that I'm able to differentiate who is speaking and who is... because, yeah. So the person who is answering, they think that what our colleague has said, they're also going with true? Hello?
Sir, my name is Emmanuel.
False or true? False, huh? The person said false?
Yes, I think it's not true.
You think it's not true, so you're saying that this is false. Okay.
Yes.
So any other person who thinks otherwise?
Yeah, sir, me, I'm thinking otherwise. I'm Emmanuel.
You're thinking otherwise by saying yeah, it's true?
Yes, it's true. The reason is that the antigen is confined in the red blood cell, which gives its blood group by having an antibody B.
Okay. I also think it's true. I think it's true because, and this is what you need to remember when you're answering questions. Always relate the question to the STEM question. So all these options are in relation to the rhesus factor. In the rhesus factor, the antigen that is present is antigen what? D, isn't it? Antigen D in the rhesus factor, where is it found? Where is the antigen D rhesus factor? Where is it found?
On the surface of the red blood cells.
On the surface of the red blood cell, meaning that it's confined to the red blood cell. So I think this one is true. Okay. C, someone to come through. Anybody, guys, we tackle more questions. We have a lot of questions. We have about 5 papers here and we only have like 15 minutes. So the more you delay, the lesser questions we answer. I don't think it would be helpful for me to just answer questions for you. I think we should explain them. Yes. Maybe I should look at this name so that I should be asking people. Is that nice? I think it's better if people volunteer.